Today, let's understand a fascinating autoimmune condition, Sjögren's syndrome, also known as autoimmune exochronopathy. It's one of the most common but often under-recognized connective tissue diseases. We'll explore what it is, why it happens, how it presents, and what every clinician should remember in practice. Definition: Sjögren's syndrome is an autoimmune disorder where the body's immune system mistakenly attacks its own moisture-producing glands, mainly the lacrimal glands that produce tears and the salivary glands that produce saliva. The result is dryness of the eyes and mouth, called keratoconjunctivitis sicca and xerostomia. This disease can occur alone, which we call primary Sjögren's, or it can be secondary to another autoimmune condition such as rheumatoid arthritis or lupus. This classification matters because treatment and prognosis differ. Primary forms need symptom-based and systemic monitoring, while secondary forms are managed as part of the underlying connective tissue disease. Pathogenesis: how it happens. At the core, Sjögren's is an immune-mediated exochronopathy. Lymphocytes, mainly B cells and CD4 T cells, infiltrate the glands, causing chronic inflammation. Over time, this destroys the axonar cells responsible for secreting tears and saliva. Autoantibodies such as anti-Rho, SSA, and anti-LA SSB appear in the blood, reflecting ongoing B-cell hyperactivity. This immune hyperactivation not only causes glandular destruction, but also increases the risk of B-cell lymphoma later in life. So the same immune process that dries the eyes and mouth also explains the systemic risk of malignancy. This understanding is key because it guides both symptom control and long-term vigilance. Clinical features: what to look for. Sjögren's syndrome presents with a combination of glandular and systemic features. Eye symptoms are very common. Patients often describe a gritty or sandy sensation, burning, or redness. They may say they can't tolerate wind or air conditioning, or that their eyes feel tired all the time. This dryness, called keratoconjunctivitis sicca, can lead to corneal damage or even vision loss if untreated. Mouth symptoms are equally distressing. The patient complains of constant dryness, difficulty swallowing dry foods, or needing to sip water frequently. Saliva has protective properties, so its absence leads to dental caries, gum infections, oral thrush, and bad breath. Many patients have difficulty speaking for long or wearing dentures comfortably. Glandular swelling is another feature. Enlargement of the parotid glands may occur, sometimes on both sides. When one gland becomes firm or persistently enlarged, it raises concern for possible lymphoma transformation. Beyond these classic features, systemic involvement is increasingly recognized. Patients can have profound fatigue and arthralgia. Some develop interstitial lung disease, causing cough or breathlessness. Peripheral neuropathy can present as tingling or numbness in the limbs. Others may develop vasculitic skin rashes or renal tubular acidosis from kidney involvement. So, Sjögren's is not just about dryness. It's a systemic autoimmune condition that can affect multiple organs. Investigations, step by step. First, we confirm the dryness objectively. The Schirmer's test measures tear production using a small strip of paper under the eyelid. Less than 5 millimeters of wetting in 5 minutes suggests reduced tear secretion. Ocular staining with fluorescein helps detect corneal epithelial damage. Next, we check autoantibodies. Anti-Rho, SSA, and anti-LA SSB are the hallmark antibodies of Sjögren's. ANA and rheumatoid factor may also be positive, reflecting autoimmune activation. These antibodies are not only diagnostic, but also indicate risk of extraglandular involvement. Then comes salivary gland evaluation. Scintigraphy or scilography shows delayed secretion of tracer material. In uncertain cases, a minor salivary gland biopsy from the lower lip is performed. This biopsy typically shows focal lymphocytic sialadenitis, clusters of lymphocytes around glandular ducts, which confirms the diagnosis. Depending on symptoms, additional tests are done, like pulmonary function tests or HRCT chest to assess interstitial lung disease, and regular ophthalmology and dental evaluations. Complications. If untreated, Sjögren's can cause several chronic problems. Eye dryness may lead to corneal ulceration and visual impairment. Oral dryness increases the risk of cavities, infections, and tooth loss. Systemic complications like interstitial lung disease or vasculitis can reduce quality of life. But the most serious long-term risk is non-Hodgkin lymphoma, especially of the MALT type. Certain red flags raise suspicion: persistent parotid enlargement, palpable purpura, cryoglobulinemia, or monoclonal gammopathy. That's why regular clinical examination and ultrasound surveillance of glands are recommended. Example clinical scenario. Let's take a common presentation. A 52-year-old woman visits with complaints of persistent dry eyes and dry mouth. She keeps sipping water throughout the day and reports frequent dental caries. On examination, her eyes are red and dry, and Schirmer's test shows minimal tear production. Her blood tests reveal positive anti-IRO antibodies. She's diagnosed with primary Sjögren syndrome. Treatment is started with artificial tears for eyes, pilocarpine to stimulate saliva, and fluoride-based dental care. She's advised regular ophthalmologic and dental follow-up and monitored for systemic features or gland enlargement. Within months, her symptoms improve significantly, and she avoids long-term damage. This example shows how early recognition and symptomatic care make a real difference. Why classification matters. It's important to distinguish primary from secondary Sjögren's. Primary occurs in isolation, while secondary is associated with diseases like rheumatoid arthritis or lupus. This classification guides treatment and prognosis. In secondary forms, management focuses on the underlying disease, such as controlling rheumatoid inflammation with disease-modifying drugs. In primary forms, symptom control and organ-specific immunosuppression are the priorities. It also affects monitoring, because lymphoma risk is higher in primary Sjögren's with strong B-cell activation markers. Long-term care and prevention. Managing Sjögren's isn't just about prescribing eye drops. It's a holistic, lifelong approach. Regular ophthalmology visits are crucial to prevent corneal complications. Dental hygiene is essential, including fluoride rinses, saliva substitutes, and regular checkups. Patients should avoid medications that worsen dryness, like antihistamines or tricyclic antidepressants. Simple lifestyle measures like using humidifiers and staying hydrated go a long way. Clinicians should remember to screen periodically for systemic involvement and lymphoma using clinical exams and imaging when indicated. Summary and takeaway. To summarize, Sjögren's syndrome is a chronic autoimmune disease targeting moisture-producing glands. It leads to dry eyes, dry mouth, and sometimes systemic complications. Autoantibodies such as anti-Ro and anti-Ella help confirm the diagnosis. Complications can involve the eyes, mouth, lungs, kidneys, nerves, and even progress to lymphoma. Early recognition and regular multidisciplinary follow-up preserve quality of life and reduce complications. So when you see a patient with unexplained dry eyes or dry mouth, think beyond local causes. Test for Sjögren's, identify antibodies, and manage comprehensively. Closing statement. This is Dr. Yogesh. I hope this explanation helps you clinically and academically to recognize and manage Sjögren's syndrome confidently. Remember, a simple question about dryness can uncover a systemic autoimmune disease early. Stay curious, stay observant, and keep learning. Thank you for watching. If you found this useful, share it with your colleagues and subscribe for more short, practical, clinically oriented videos.